My name is Arjun Balar. I'm a medical oncologist and director of GU Medical Oncology at the NYU Perlmutter Cancer Center, and I'm also an associate professor of medicine in the NYU School of Medicine. Keynote 57 is the study that I presented on Friday morning at GU ASCO, and this specifically tested pembrolizumab in a patient population consisting of high-risk non-muscle invasive bladder cancer patients that were no longer responsive to BCG immunotherapy. We specifically looked at an updated interim analysis of the first 102 patients that were treated on this trial. So what this study did is focus on patients with BCG refractory disease, and it was specifically defined as patients who had received at least adequate induction BCG and then were unresponsive. And specifically unresponsive patients included those who were BCG refractory, which means that they basically had progressive disease that never had a response to BCG, or they were BCG relapsing, which meant that they had initially achieved a disease-free state but then had relapsed within 12 months of receiving adequate BCG. And so what we looked at in the 102 patients analyzed in this particular study at a median follow-up of roughly about 16 months is that the complete response rate in the bladder, which means eradication of all the carcinoma in situ with or without papillary disease, was 40%. Of the patients who didn't respond or others who had progressed and ultimately came off study, none had developed muscle invasive or metastatic disease, and that's a very important consideration. Now the question is how good is the response and how durable is it in this patient population? And the background as to why that's so important is that many agents have been tested in this salvage setting where they can induce responses in the bladder, however they're rarely durable. And so ultimately this CR rate of 40%, is it durable? For the patients who achieved a CR, the median follow-up now is about 17, 18 months, so it's actually we have some decent follow-up in these patients, and that about 53% of those CRs are actually lasting 9 months or longer, and the median duration of the CR is around 12 and a half, 13 months. That's a Kaplan-Meier estimate. We will need longer-term follow-up to demonstrate how durable these are, but these are encouraging data preliminarily from the first 102 patients. BCG unresponsive disease first requires that patients have received adequate BCG. What does that mean? Adequate BCG means at least 5 of 6 induction installations and at least 2 of 3 maintenance induction installations, or at least 2 out of the next 6 reinduction installations of BCG. And that's required because we know from earlier data with BCG, dating back many years, is that a course of induction BCG, while that may not lead to a complete response in the bladder, either reinduction with BCG again, 6 installations, or possibly a course of maintenance may ultimately lead to a complete response in the bladder. And so that first has to be core definition, is that patients must have received adequate BCG. And that was used as the definition in this protocol. Next is to then define, are you unresponsive to BCG? And that included 2 definitions. Number 1, BCG refractory, and then the other is BCG relapsing. And patients that had either of those were considered BCG unresponsive. BCG refractory are patients who have either stage progression, which means they had non-invasive disease and upstaged to T1 disease after first induction, and those are the highest risk patients, and many would argue should go to radical cystectomy. And there are others that despite adequate BCG, they still have persistent disease at 6 months. And these are the patients that we collectively call BCG refractory. BCG relapsing is a slightly different patient population. These are those who, after adequate BCG, have achieved a disease-free state, which means a complete response in the bladder, however relapse within 12 months of receiving adequate BCG. Collectively, BCG refractory, BCG relapsing, that combined includes all patients who are so-called BCG unresponsive. And that's how patients were defined in this protocol. I would argue that the overall toxicity profile that was demonstrated in this Keynote 57 update is actually identical to what we see in systemic therapy trials involving systemic PD-1 blockade and metastatic urothelial cancer, and overall is very well tolerated. What we see is that only 2/3 of patients report any adverse event related to immunotherapy in this trial. That meant that 1/3 reported no events whatsoever. And even of the patients who have more higher toxicity, which is grade 3 and 4 adverse events, it was only about 12%. And virtually all of these are controlled with immediate administration of corticosteroids, and the symptoms go away. So while even then, let's say the rate of grade 3 and 4 adverse events may be high and perhaps unacceptable to some individuals, though with proper intervention, the duration of the adverse event usually does not last very long and can be treated very well. In fact, only 8 patients out of the 102 discontinued treatment due to a treatment-related adverse event. I think one of the most important considerations to make in this data set is, number one, are patients progressing to muscle invasive or potentially metastatic disease if they are not responding to PD-1 blockade? And what we see so far is, of the patients who did not respond or those who responded and then ultimately progressed, none had progressed to muscle invasive disease. So that's very important. Number two is that if patients achieve a complete response in the bladder, how durable is it? So far, it appears at least half of the complete responses are durable beyond 9 months and perhaps a year or more. However, the median follow-up for the patients achieving CR is still only about 17 or 18 months. So we need longer-term follow-up. Longer-term follow-up will mean a minimum of 2 years in follow-up for patients who achieve a CR to truly see how durable they are. If the outcomes with checkpoint blockade and metastatic disease are any lessen to what we might see in non-muscle invasive disease, we know that patients who achieve a CR and PR in metastatic disease, those can be durable even off of treatment, lasting many years. I'm hopeful that we will see similar outcomes in patients with non-muscle invasive disease.